Hello, everyone. Welcome to week 2 and chapter 3, Assessment and Classification of Mental Disorders. Here we have a brief overview. We will discuss reliability and validity. We will take a look at assessment and classification. We will take another look at the DSM-5, including cultural considerations, and we will end, as usual, with a discussion about trends, future directions, and a slide of review questions. We're going to take a quick look at reliability and validity in this chapter. You'll also notice that there's a video posted in Moodle that offers another explanation about reliability and validity. That will be a great resource to come back to as you're working to fully understand these two concepts. Reliability is the degree to which a test or procedure yields the same results repeatedly under the same circumstances. When I think about reliability, I think about consistency. Is this going to consistently give me the same results if it is done in the same circumstances? So we have test, retest reliability. So we would expect to get the same results when we give the same test at 2 different points. We also want to consider internal consistency. This is referring to different parts of the assessment tool or the measurement all measuring the same thing. So if we were using an assessment tool to look at anxiety, all of the different parts or different questions are relevant to measuring anxiety. And then we have inter-rater reliability. This is consistency of responses when scored by different test administrators. So regardless of who is administering that test or assessment tool about anxiety, we're still going to get the same or very similar scores. That tells us that that test is reliable or consistent. We next have validity. Validity is the extent to which a procedure actually performs its designed function. So when we talk about reliability, like we did in the last slide, I'm thinking about consistency. And when we're talking about validity in this slide, I am thinking about, is this measuring what we're looking to get measured? Is this measuring what we're saying that it's going to measure? 3 types of validity that our text talks about and that we should know: predictive, construct, and content. Predictive validity, how well a test predicts a person's behavior or response. Construct validity, how well a test or measure relates to the characteristics or disorder in question. And content validity, how well a test measures what it is intended to measure and assesses all areas known to be associated with a particular disorder. So for content validity, especially important to note is that there are going to be different aspects or different features of certain disorders, such as depression. And in order for an instrument to be valid, it is going to consider and measure each of those different features that we know are associated with depression. Standardization refers to the standard administration of an instrument. As a mental health professional, it is important to administer a test or an assessment tool following the common rules or procedures expected to be used with that test or assessment rule. So for example, some assessments have been normed and standardized using very specific language, and it's important for us to stick and stay true to that language in the questions instead of veering from it in order to ensure that we are having valid results. We're going to talk a bit now about assessment and classification of mental disorders. We began with a conversation about assessment more informal assessment last week in our class activity as we were getting used to the framework, using the framework of the multi-path model. And as we talked about in class, assessment is about gathering information and drawing conclusions from that information. There are four main assessment methods: observations, interviews, psychological tests and inventories, and neurological tests. We're going to talk briefly about all of those assessment methods in this lecture, and your text does dive deeper into each of those. Observation. So observation could be controlled observation, naturalistic observation, or even more of an informal observation, which I referred to as it relates to the case study that I presented in class last week. A controlled observation would typically be made in a very controlled setting, such as a laboratory or a clinic, and the professionals would be controlling for many variables and looking at very specific behaviors. Naturalistic observations are going to take place in a bit more of the informal settings, maybe in a classroom or maybe in our office or maybe even at home when we might be looking at something such as parent-child interaction. And the last most informal type of observation is to observe appearance and behavior. And we talked about how we begin to do that from the very first interaction with a new client or patient. Another type of assessment method is interviews. Interviews can be structured, semi-structured, or unstructured. In interviews, we observe the client and collect data about the person's life history, current situation, and personality. And we are taking note of and paying attention to both verbal and nonverbal behavior, as well as the content of what they are telling us and how they're telling us and how they present when they tell us that, and their process of communication. Again, types of interviews, the degree of structure varies from structured, semi-structured to unstructured. Structured interviews have common rules and procedures, a standard series of questions that are asked in a very particular way, and some of the disadvantages, the key disadvantages, that it limits conversation and limits the clinician's ability to probe and ask more questions. And some of the advantages of a structured interview are that we collect consistent and comprehensive information. One type of interview is a mental status examination. The objective of this interview is to evaluate the client's cognitive, psychological, and behavioral functioning. We ask questions, make observations, and present the client with tasks. We're specifically looking at these areas of focus. We are assessing for appearance, mood, affect, speech, thought process, thought content, memory, abstract thought ability, and general knowledge. This helps us to form an initial diagnosis and consider initial treatment needs. Psychological tests and inventories are standardized tools that measure characteristics such as personality, social skills, intellectual abilities, or vocational interests. These tests differ in degree of structure and degree of objectivity. We will take a look at the projective personality tests. We have a list of some of the most common projective personality tests here. One of the most popular is the Rorschach technique. In these tests, the test taker, which would be the client or patient, is presented with an ambiguous stimuli and asked to respond in some way to that stimuli. There are some concerns with projective personality tests in that they do not meet reliability and validity standards. Their analysis and interpretation of responses is very much subject to clinician discretion, and there can be quite a wide variation in that interpretation, and they may have limited cultural relevance. Self-report inventories are commonly used in clinical settings. Self-report inventories are used to assess personality or other symptoms such as depression, anxiety, or emotional reactivity. And these inventories often involve either completion of open-ended questions or responding to a list of descriptive statements. Sometimes we have clients respond to a list of descriptive statements and answer on a 5-point Likert scale. Some examples that our text talks about is the MMPI or the MMPI-2. They make note that interpretation is very complicated using this instrument and that it's important to be well trained prior to implementing this instrument. Very common self-report inventory that we use to screen for depression and as an initial assessment instrument for depression is the Beck Depression Inventory. Lots of other inventories such as maybe the audit, the alcohol use, to assess for alcohol use, or the DAST to assess for other substance use, or the PHQ-9 to assess for symptoms that might be related to depression or another mental health disorder. And these self-report inventories also have some disadvantages, mostly that the client may not always feel as though one of the options for response best fits with their experience, or they may not feel comfortable answering truthfully because of what is acceptable social norms or not feeling fully comfortable with the provider. This, I think, is really important for us to consider because even though we're talking strictly about assessment here and we are not diving into treatment planning or treatment intervention, it is still very important to be considering how we're developing a relationship with this person, as that is going to strongly influence the information that we get in our assessment. And our assessment is that first chance that we have to start identifying client strengths and building hope. So we use some of these instruments and we do some of this interviewing, and how we do that in order to get an accurate assessment and how we do that in order to begin building hope is very, very important. These next few slides are about intelligence tests. Intelligence tests' primary functions are to obtain an IQ or an estimate of the current level of cognitive functioning and to provide some clinical data around that cognitive functioning. Two of the most popular intelligence tests that we want to be able to remember for this class would be the Wechsler scales and the Stanford-Binet. Some criticisms of the intelligence tests are that they fail to consider the effects of culture, poverty, discrimination, and oppression, and do not consider multidimensional attributes of intelligence. They have a poor level of predictive validity, especially for minority groups. So even though intelligence tests have been around for quite a while and still may be widely used, it is very important to consider the multicultural considerations and that oftentimes they're not accurately predicting future ability for future achievement or predicting future behaviors. Tests for cognitive impairment. So we're going to talk in a little bit about other neurological tests and tests for cognitive impairment. Oftentimes, clinical psychologists are the mental health providers who are implementing this type of assessment for cognitive impairment and for the neurological tests. These tests noted here are used frequently in order to determine levels of impairment resulting from potential brain damage. And here we have figure 3.3 from our text that gives an example of the 9 Bender designs. So each of these designs would be presented to the client or the patient on a white card in black black ink on a white card, and that client or patient would be asked to draw them, and there are some common errors that would be associated with key cognitive abnormalities. Next, we're going to take a look at some various neurological tests. Table 3.1 and 3.2 in our text offer great description of each of these structural imaging techniques and the functional imaging techniques, in addition to a column about not only the description, but what is detected in that test. And I would encourage you to look back at that. However, we do not need to have a full understanding of these tests for this course. Diagnosing mental disorders. So we are going to be coming back to the DSM-5 again, which is what the classification system that most mental health professionals use to diagnose individuals. The first edition of the DSM was developed in 1952. The second edition came out then in 1968 with just under 80 additional mental health disorders. And then there was the third 3R, and the fourth editions and revisions. And currently, the most recent edition is the DSM-5. And in all of these revisions, the work groups and the individuals involved in completing the revisions and the editing were very cognizant and intentional about trying to increase the reliability and validity of these diagnoses. So here in slide 22 and 23, we have the categories and features of the DSM-5 disorders. So if you were to get out a DSM, this is kind of what you're going to see as a table of contents. So the disorders are broken down into these sections, and it gives us a description here of what would be common to experience with each of these disorders, and that's continued here into these other disorder categories. Inter-rater reliability of the DSM. This indicates inter-rater reliability for adult diagnoses, and this next slide here indicates inter-rater reliability for child diagnoses. You see for the adult diagnoses, the major neurocognitive disorder, post-traumatic stress disorder, and complex somatic symptom disorder have the highest inter-rater reliability, and some of the disorders with the lowest inter-rater reliability include some personality disorders and also major depressive disorder and generalized anxiety disorder. And this maybe is interesting to some of you to see the inter-rater reliability be so low for MDD or GAD. And part of what this highlights is the overlap in symptoms for these different disorders and how easy it may be for different clinicians to propose or suggest or offer different diagnoses for same presenting symptoms and presentations, especially as it relates to some of these disorders that are lower on the inter-rater reliability. And this goes for children or child diagnoses as well. Chapter 3 talks about this dimensional perspective. So refers to how the DSM-5 is a categorical model, and some professionals believe that it's not as effective for diagnosis and that a dimensional classification system might be more effective as it considers how disorders reside on a continuum from normal to severe forms of each particular disorder. This is just something for us to continue to keep in mind as we continue to dive into these different disorders and the DSM, and for you to begin to consider, does the DSM seem to fit for you, or does this continuum model make more sense for you? And actually, part of the DSM does bring in more of that continuum model, especially as it relates to alcohol use and to substance use. And this was not true in the DSM-4. So in the DSM-5, they moved away from the terms of abuse and dependence for alcohol and substance use and moved into more of a continuum diagnosis of alcohol use disorder, mild, moderate, or severe, and substance use disorder, mild, moderate, or severe. So continue to think about that and think about, based on your experience, based on your understanding of this class's content and other classes that you've had, what makes most sense to you. So the final version of the DSM-5, it does remain that categorical system with just some of those exceptions like I talked about, especially with alcohol and substance use. It uses subtypes, specifiers. You indicate if an individual is in remission or not, and you're also looking at some comorbidities or the presence of 2 or more disorders within the same individual. You will see really quick and easy definitions for all of these: subtype, specifier, remission, goes into comorbidity and prognosis too on page 93 of our text in chapter 3 if you have any questions about what those are. Cultural factors in assessment. So determining whether a behavior is consistent with cultural norms is the responsibility of the clinician. It's also the responsibility of the clinician to consider our own bias and how that might be influencing our perception of the client. The DSM-5 includes some guidelines for conducting a cultural assessment, and this is 16 questions. And if anybody has any interest in that, I typically have my DSM with me in class, and so feel free to stop in before or after, and you could go ahead and take a look at what the DSM suggests for those 16 questions in order to conduct a cultural assessment. Our text begins to give us an example about a few of these questions that provide a guide for conducting a cultural assessment, and some of these questions include things that help us better understand the client's lived experience. And so the first one that the text refers to that's in the DSM-5 is, what do you think is causing your problem? So what is attributing, what do you attribute this to? Why is this happening to you? What have you done to cope with this? And then it gets into some strength questions too, and how this has specifically impacted that person's life. I think this is a great start, but I do also think that cultural humility and understanding our own bias are also really, really important factors. Changes in the DSM-5 classification system. So changes in the criteria for some disorders may increase the number of individuals receiving a diagnosis. An addition of some disorders in the DSM may also increase the number of individuals receiving a diagnosis. An example of this is related to behavioral addiction. So gambling disorder would fall under this umbrella, but also other addictions such as to video games or screen time or shopping, eating, all of that would fall underneath this umbrella. And so part of this is information and kind of to be used as food for thought. What do you think of this, and how do we consider this as we move forward with new proposed changes and new versions of the DSM in the future, related to changing criteria, adding disorders, and how does that best serve the clients that we're working with? Does that serve them to have a list of more disorders in their health records? Or does that not serve them? And do we then kind of step into over pathologizing? Objections to classification and labeling. So some concerns with this piece of labeling and diagnosing and providing a specific disorder are, these are kind of the big top three, and for sure the three that our text talks about. So labeling could lead to overgeneralization, stigma, and stereotypes. Labeling may lead to a person taking on particular characteristics or really believing this to be more true about themselves. And labels are on some levels, on lots of levels, required by our social systems, especially by insurance systems for reimbursement and by insurance systems in order to access treatment. However, they do not provide precise information that is sometimes required by healthcare organizations. So oftentimes we wonder, how useful is this? How useful is providing a diagnosis or a specific disorder? Will that labeling potentially create more harm or cause more harm than we will do healing for that individual? And on the other side of that, sometimes having that label, being able to name that thing and separate it from themselves can be really useful and healing for treatment. We're going to end here with a quick discussion about contemporary trends and future directions. So current trends definitely revolve around focusing on an increased reliance on the biological model. So advances in biological and neurological research are huge, and how we're tying that into what we do as mental health providers. There is an effort to discover specific biomarkers. There is increased consideration of other factors in addition to the biological factors. And there is growing consensus that mental health professionals are not merely objective observers. This idea that mental health professionals are not merely objective observers speaks to the need of mental health professionals to increase our self-awareness in order to really take a look at what we bring to the room and what we're bringing to that client interaction, and how that influences how we perceive and how we understand the client or the family or the adolescent in front of us. So we have to take a hard look at our own biases, our own stereotypes, work really hard to do our own work to increase our own self-awareness in order to become effective mental health clinicians. We made it to the end of chapter 3. Here we have some questions for you to consider for reflection and review. We can come back to some of these questions in class if you have any desire to do some clarification. Otherwise, go ahead and jot some notes down about this. And I look forward to seeing everybody this week after a long Labor Day weekend. I hope you all are staying healthy and safe, and I will see you soon. Bye-bye.